Welcome back to Diabetic the Files. Forgive me for being so late, long day. So today we're going to talk about something I keep on harping on, and I've done episodes on it again and again, but it kind of irks me because I don't think this is a diagnosis that people should miss because it's actually life or death when it's missed. And my last episode, I explained how there was a gentleman who was the mortician and she was doing autopsy, I guess. I'm not sure. The person who does the autopsy, the forensic autopsy. And she found out that he died because he had necrotizing fasciitis and they put a cast on him and they didn't know it was neck fast. They just thought he had arm injury. So I want to go through this again. So it could be a diagnosis that nobody can ever miss again because it is life and death and we should be caring about that, right? So let's talk a little bit about the history of necrotizing fasciitis and like how it was discovered, okay? So ancient descriptions of a rapidly spreading flesh-eating infection date back to Hippocrates. So that's like 5th century BCE. And he described patients with rapid tissue destruction, severe pain, systemic collapse, high mortality. He observed that aggressive early incisions sometimes improved survival. Even then, physicians understood that delay meant death. And keep that in mind. Delay means death when it comes to neck bash. So, in the 18th to the 19th century, during military conflicts such as the American Civil War, surgeons documented a rapidly spreading tissue necrosis in wounded soldiers. And it was called what they call hospital gangrene or phage- phagedema or putrid ulcer. And the treatment at that time was immediate amputation, caustic agents like nitric acid or carbolic acid irrigation, and the mortality rate still was extremely high. So, the formal definition in 1924, the formal definition, the term necrotizing fasciitis, was formally coined by Dr. B. Wilson. He described fascial plane destruction secondary to skin necrosis, relative sparing of muscles early. So, this is a critical insight because the fascia dies first. So, what did they use for treatment back then? So, before antibiotics, they did wide surgical debridement, which is still what we do, amputation, hot iron cauterization, and hypertonic saline irrigation. And after antibiotics, which was like 1940s and 1950s, penicillin definitely for streptococcal infections, but surgery remained essential. So even today, like I said, surgery is still the definitive treatment for necrotizing fasciitis. So, necrotizing fasciitis actually has a classification system, and they're classified in types, and there's about four types. So, type 1 is polymicrobial, and this is the one that is most common in diabetics because most diabetic ulcers are polymicrobial. So, this means that there are organisms that are gram positive, gram negative, and anaerobes. Common in diabetic foot infections, post surgical wounds, immunocompromised patients, high gas production possible. Type 2 is monomicrobial. So this is something like group A strep. So most often Streptococcus pyogenes, sometimes with Staphylococcus aureus, more common in healthy individuals, minor trauma, young adults. So produces exotoxins, streptococcus, pyrogenic exotoxins, super antigen effects, cytokine storm, and this type is usually associated with streptococcal toxic shock syndrome. Now, type 3. Type 3 is clostridal. So, this is a gas gangrene variant. So, the organism of this is Clostridium perfringens, and they produce alpha toxins, massive gas, and rapid myonecrosis. This form can progress within hours, extremely fast. And then the fourth type is fungal, which is I really didn't know that much or well versed that there is a fungal necrotizing fasciitis. I always thought it was just bacterial, but there's a fungal one, and you see it in immunocompromised patients, trauma patients, or burn patients. And the organisms for that would be Candida or mucormycosis. This is a very rare type of necrotizing fasciitis, but also quite deadly. So, what are some famous real life cases of necrotizing fasciitis? A Slayer guitarist named Jeff Hanneman, he developed necrotizing fasciitis after a spider bite, so a suspected brown recluse, and complications were severe tissue loss, required multiple surgeries, contributed to long-term health decline, and this case helped raise public awareness. So, the thing about necrotizing fasciitis, it does present sometimes atypically because that's why some people have a hard time diagnosing it because they're like, oh, this patient is young, healthy, things like that, right? So, or somebody who has a minor strain and they sometimes misdiagnose it as compartment syndrome, okay? And they find out in the OR that it's necrotizing fasciitis. So, keep that also in mind. But one of the key factors is like deep pain, okay? But we have to remember with diabetics, their pain might be masked through the neuropathy. So, when it comes to the latest research, modern research highlights early cytokine markers. So, the early cytokine markers that are elevated when it comes to necrotizing fasciitis are IL-6, procalcitonin, and TNF alpha. If y'all haven't realized, IL-6, TNF alpha, 1 usually are cytokine markers for infection. So, procalcitonin may help differentiate cellulitis versus deep necrotizing fasciitis. Might help, just keeping that in mind. So, next, point of care ultrasound. So, recent studies have shown ultrasound may be able to detect the fascial fluid greater than like 2 millimeters, subcutaneous air, and a thickened fascia. So, the ultrasound is emerging as an early bedside tool to help diagnose necrotizing fasciitis. Now, now they also have like you I think everybody knows the LRINEC score. That's also helpful. So the LRINEC score, what does it stand for? So LRINEC score. So it stands for Laboratory Risk Indicator for Necrotizing Fasciitis. And they have a point system. They use 6 laboratory findings. So CRP, white blood cell count, hemoglobin, sodium, creatinine, and glucose. And they have points from 1, 2, and sometimes even 4. Like if the CRP is greater than 150, that would give it 4 points, okay? But the interpretation is if it's less than 5, that means it's less a low risk of necrotizing fasciitis, but having less than 5 does not rule out necrotizing fasciitis. If it's 6 to 7, that means the patient is more at an intermediate risk of necrotizing fasciitis. But if it's grade 8 or higher, high risk of necrotizing fasciitis. It has its sensitivity limitations in the early disease formation. Okay, so keep that in mind. Honestly, it's better to rule out and say, "Let's make sure it's not neck fast," than to say, I don't think that's neck fast. I think it's just cellulitis," because it always ends either in the amputation or somebody's dying. So let's be more precautious and want to rule it out instead of just saying it possibly isn't. So that's the best thing. So, what are some key labs that can help save lives? Look at the CRP. CRP, draw CRP. If it's greater than 150, that is a very strong red flag. If you see the CRP elevating, something is going on. Something is going on, okay? Hyponatremia. So, like if the sodium level is less than 135, that usually happens when you have systemic inflammation and a capillary leak. Next is elevated lactate. So, elevated lactate, what does that indicate? Indicates tissue hypoperfusion and sepsis. And then a raising creatinine level shows renal hypoperfusion. And then a CK elevation usually shows muscle involvement. Is there a foolproof strategy not to miss a necrotizing fasciitis diagnosis? And the truth of the matter is, nothing in medicine is completely, truly foolproof, but let's get as close as we can to try to make it foolproof. So one of the biggest things is speak to the patient. Is your pain out of proportion? If it's yes, escalate immediately, investigate more. Stop. I hate when people are downplaying patients' pain. Next, step two, look for rapid progression. Reassess within 4 to 6 hours. Necrotizing fasciitis evolves very dramatically. And the fact of the matter is, you should be drawing labs. Like a lot of people be like, oh, you're drawing unnecessary labs. But then if it is medical negligence and somebody dies or has an amputation because they didn't draw labs, then they're like, oh, so better to draw labs than not to. If there's systemic toxicity, so think about skin findings. And then, like I said, use labs aggressively. So draw CBC, CMP, CRP, lactate, blood cultures, okay, and calculate a LRINEC score. Now, when it comes to imaging, a low threshold, but CT if the patient's stable, and like we always say with neck fast, do not delay surgery. If you're thinking that it's possibly neck fast, definitely get the general surge or whatever department is supposed to be. They would call podiatry if it's on the lower extremity department to take that patient to the OR. Make sure the patient's MPO. Step 7, start empiric IV antibiotics. So typical regimen for necrotizing fasciitis is IV vancomycin or IV piperacillin tazobactam, so that's docin, or clindamycin. And then, oh, I forgot another one. There's another one. There's actually like, is it meropenem? I have to double check because that was in the actual textbook. But clindamycin actually suppresses the toxin production in Streptococcus pyogenes. So that's why I love me some clindamycin. But trust your clinical judgment. If your gut is saying something wrong, and it should be saying something wrong because a patient comes into the hospital if something they feel like something wrong. So never downplay patient's symptoms, okay? It's better to go with caution and rule out and make sure that this isn't a situation with life or death, like I said, than actually downplaying the patient's symptoms and saying it's nothing, okay? So they also think of doing, I've read about this, they say a finger test. A finger test is doing a small incision, probing along the fascia. The lack of resistance shows a bad sign because it already eating against the fascia. So why does delay in the diagnosis of necrotizing fasciitis kills? So the mortality rate increases dramatically if surgery for necrotizing fasciitis is delayed beyond 24 hours. Early debridement, they usually have a 10 to 20% mortality. If it's delayed, it up to 60% mortality. Time is fascia. Just like if they say time is tissue, time is fascia. So in diabetics, where do they usually get necrotizing fasciitis? Usually along the plantar compartment is common. Infection may track along the flexor tendons and may be mistaken for an abscess. So if you're debriding a diabetic foot wound or ulcer in tissue and it looks gray, non-bleeding, one of the other key factors is dishwater drainage, gray dishwater drainage. Okay. And, they do extend incision. Definitely do not close. We know better. And, do not pack lightly. And it's a wide excisional debridement, pretty much, or amputation if it's going past a certain level and per recommendation of gen surge or vascular. So, final message is necrotizing fasciitis is not missed because it hides well. It's missed because people usually hesitate or downplay other patients' symptoms because sometimes they want to rationalize and say, oh, I hope that it's cellulitis instead of necrotizing fasciitis. And, that could be between life or death. So in wound care and podiatry, this death diagnosis also defines our careers and makes a difference. So remember the case that you caught. You'll always remember the case that you caught a neck rash. Who doesn't? And you will never forget if you missed one. I would hope that somebody has the empathy and guilt if they missed necrotizing fasciitis. Okay. So I hope this episode was very helpful for everybody. And end goal of the day or the message is try your best and forgive for the cough. Try your best not to miss necrotizing fasciitis and forgive the cough in the background. It's very late. And take care of your feet because they take care of you. This is Dr. G with Diabetic with Files. Thank you.